So as mentioned, I'm going to focus largely on the work that we did for the OIE around managing the emerging disease risk in the wildlife trade, and really from an implementation perspective. So this happened, well, about almost a year ago. We were working on this quite diligently for the OIE. They were the knowledge user who retained us to work on this group, on this project. And what they asked was to look at the peer-reviewed literature to inform the development of guidance to reduce the risk of disease emergence in the wildlife trade. There was something I think that was really important in the contract, was that in red there, to build on rather than duplicate previous reports on the topics. So they were looking for some maybe different viewpoints on what we were seeing and how we were looking at the literature. The original report was done between December 7th of 2020 and February 15th, looking historically back in the literature. As a little bit of an update to that, we are refreshing our literature review as we speak. We haven't finished it right now, but just so you know, so far, it's looking like all the conclusions that you'll hear about today are not going to be changed by what we're finding so far in the updated literature review. So let me first talk about avoiding duplicating. So we came into this project with certainly a background working on wildlife issues and One Health issues. And we knew that that there was a need to add a doing lens. In other words, we really wanted to focus on actions that would reduce risk. And we knew there was a deficit in the doing lens in the literature. This is an old review we did, maybe about 5 or 6 years old now, where we looked at the top journals publishing on wildlife, fish and wildlife health. 469 papers. And if you can see down there on the bottom, only 4% of them actually were asking, how could we control this wildlife disease issue out there in the real world? And of those 4%, many of them were just sort of a one-off trials, feasibility studies, not evaluated to actually see if they remedied the problem in a long-term sustainable way. So you can see there's this heavy bias towards finding things that could go wrong, looking at the proximate risk factors and sort of the basic science behind those. Now, that is not unique to wildlife disease. This was another review we recently did looking at what's the literature telling us about climate change adaptations for animal health in general, so livestock and wildlife and companion animals. So we had 1,341 studies that had the words climate change adaptation and animal health in a literature review, but only 36 of those were talking about we should do something. The rest of them are really describing what could go wrong. So they would have in their, introduction, climate change adaptation, and we should add, we should do climate change adaptation. Of those 36, 15 of them were really saying, well, some animals are just going to be innately better to deal with climate change. 9 of them talked about we should modify the natural environment so wildlife can move, and 6 of them were about affecting animal husbandry, but none of them were evaluated to see could the recommended change actually increase climate change adaptation. So we really wanted to make sure we focused on literature that talked about doing and managing and reducing risk. The second thing we wanted to do to avoid duplication was add what we'll call a vulnerability lens. Because of what we found in the past about wildlife literature, we knew that for things like an emerging disease, if you waited for infection, disease, and death as your end point for study, you will always be too late. In other words, you're always responding rather than preventing. And so focusing on death, disease, infection could limit your insights into opportunities for harm reduction. So we wanted to think about this from a vulnerability perspective, which of course has 4 components to it. What affects your exposure to the etiological agent that could cause your harm? What affects your sensitivity? And that's not just your immunological susceptibility, but what makes you or your population more prone to be harmed by that problem? And then adaptive capacity, which has 2 parts to it. Can you resist the harm when it first happens? And can you cope with it, recover, or bounce back? So we wanted to think about all these arms of vulnerability when we were looking and reviewing the literature. Our third way to avoid duplication is we wanted to use a social illness lens. And it's a bit of a made up term. What I mean by social illness, what was it that Hippocrates said? A disease is what has you, the illness is what you have. In other words, illness is your experience of the disease. So with wildlife health, we respond to the social experience of the disease, yet we tend to just study the disease. So we look more at wildlife diseases that could be zoonotic or could have an economic impact rather than something that might, for example, impact a cryptic, amphibian that isn't a species at risks. We tend to look more interest on charismatic species than non-charismatic species. Why that's important is the illness is the problem that society really responds to, not the disease. And that's important further because for free ranging animals, there's very little we can do to manage the pathophysiology of a disease. So if we take that vulnerability lens and think about the illness, we wanted to see could that open the imagination of what we could do to manage the problem. So our driving question for this review was, does the peer-reviewed literature meet evidence-based expectations for program implementation and sustainability to reduce emerging disease risks in the wildlife trade? So that was our guiding question. And there's different studies along that spectrum of that question. So we have sort of 5 general study types that we think about, from figuring out there's a problem to figuring out what to do about it. So on the far left side is detecting the risk and describing the problem. So what is it that's causing this harm? What is the new disease? What's the etiology? How's it causing problems? The next level is, well, what are the causal relationships that we might be able to manipulate? So risk factors. Can we find and have confidence in what a risk factor is? And once we find those risk factors, we might want to modify them through some sort of intervention. Efficacy studies ask, can we change outcomes under ideal situations? Effectiveness studies now ask, does that intervention work under relevant real world conditions? And finally, implementation studies, what makes it work for whom, under which circumstances, where, and for how long? In other words, just trying to take those often very limited studies and generalize them. So we were very interested in finding evidence of effectiveness and implementation. In other words, things that would work in the real world to reduce risk. So we had to develop a conceptual framework to organize our information. And we had to go to public health. There's a large implementation science gap in animal health and conservation, though it's, I think, better recognized in the conservation literature than in the animal health literature, that we need to figure out how to study program evaluation and implementation. So we looked at this sort of general standards out of health implementation programs. The 4 general standards are, what is the utility, feasibility, propriety, and accuracy? In other words, accuracy, does it actually reduce the thing we're worried about? So are we trying to change risks? Are we actually showing risks is being changed? Are we trying to change behavior? Are we showing behavior is being changed? Propriety, is it ethical, equitable, legal? Feasibility, do we have the skills, the resources, the knowledge to do it? And utility, can we actually do it? And there's elements to try to identify these standards, like we want to see, are stakeholders engaged? Was the program well designed? Did they have a focused design, evaluation design in the studies? Was the evidence credible, justifiable, and were they shared? One thing that really helped us with this is what's known as the re-aim framework. So this is used to help look at how to translate research into action. So the R, reach, were people reaching the targeted population? In other words, was the program reaching the people who could affect the change of risk? Effectiveness, we talked about that. How do we know if it's effective? Adoption for the A, is there institutional support to deliver the intervention? And institutional could be government, it could be a community, it could be a farmers co-op, it could be a variety of groups, but do you have support to do it? Implementation, do I know that the intervention is being properly delivered? For example, we've all heard of great plans for vaccine programs, but there's no cold chain to deliver the vaccine. So can you implement this ideal intervention? And then maintenance, do we know the interventions incorporated and used over the long term? So those sort of things were all in influencing our review. And I just wanted to give you that background so you can see our thinking as we went forward on this. So what did we find? First off, we set out to frame the problem, to try to examine the boundaries of the issue. And I probably don't have to go over this in too much detail for this crowd, but just bear with me as I summarize it. This is one that seems completely obvious that isn't necessarily. Wildlife is not a species or a commodity, but a vastly diverse group. And I say that because many of the groups who are used to controlling animal health risks are used to working with cattle. Yes, cattle held by, for example, the Maasai in pastoral systems or in Mongolia might be different than cattle that are reared in a dairy farm in Wisconsin or in a feedlot in Canada. But they're cattle, similar physiology, similar diseases, right? Same with poultry. We can have diversity of poultry systems, but that's very different than saying we're going to put together a marine mammal fur industry with a food from an animal, with some leather from another animal, with a pet market, with animals used in the wildlife trade for um, uh, captivity, whether it's pets or zoos, whether they're used for experimental purposes. So to say the wildlife trade and somewhat decreases that great diversity. Similarly, the trade, therefore, itself is very diverse and very diffuse and highly variable. This is a very generic model we made up early on to think our way through the wildlife trade. And you can see it starts at the left-hand side with animals living free on their own. They're either harvested, killed on site, captured, or hunted. Some go to slaughter or butchery. Some go to live food, whether it's pets, laboratories, or others. There's local handling and local transport and local markets that go to local end users or then feed into cross-border transport, international holding, distribution, and final use. And we can easily find in the literature that people have found pathogens of concerns throughout this generic supply chain. We can certainly find pathogens of concern in free ranging wildlife. We can find them in animals that have been butchered or eaten. We can find them animals that are being held in international movement centers and in end users, whether that's on somebody's plate or monkeypox in a pet or something like that. So that background is just to really say that there's a high context specificity to the wildlife trade. One size fits all is not going to work to reduce risk. And we know that for any sort of complex supply chain where there's high context specificity. And that's when we've looked sort of at some of the literature. Some of the things we did this review was to look for literature outside of our formal review. So we got some more context. And we know that these complex, high context situations, the constraints and opportunities to reduce risks are highly influenced by local situations. What are the animals? What is the trade? What is the economic capacity? What's the regulatory ability? What's the knowledge? All those sorts of things. So that means your critical control points are going to be locally determined in a pragmatic operational way. Because it is a complex supply chain and complex supply chain risk management principles, it will tell us that single point interventions are going to be inadequate. So just saying we're going to do this one thing and risk will be reduced is unlikely to truly going to reduce our risk. And that means that we're going to have strong partnerships, communities, and systems thinking to try to work across the supply chain. And finally, because of this context specificity and still large uncertainties and ambiguities in the literature, you're going to have adaptable management. So you're going to have ongoing monitoring evaluation of whatever you do to see, is it doing what it's supposed to do? Is the process working? Are the outcomes happening? Are we learning more? How do we change it? And have monitoring because there is going to be a high likelihood of unintended consequences because it's this big, complex, and connected to many different things. Pulling one thread on that sweater of risk might unravel something somewhere else. So let's look at reviewing the evidence. Certainly, when we look back in the evidence, the key words, this is sort of how our literature distributed itself over time. Certainly, you can see in the last 20 years, there's really been an explosion of literature on this topic. 2021 is very low because of the timing of our literature review. I'm sure it's much higher now when we look at our updated review. So you can see it's not, although there's an abundance of literature on the topic, it's not necessarily an old literature on the topic. And that reflects, of course, the interest in emerging diseases that have happened in the last few decades. So this sort of busy slide is the summary of what we did for our literature review. So let me just walk you through this. So we started off by asking at the top left, um, is there causal evidence between the wildlife trade and pathogen spillover? So this was our sort of our way to ask, can we find evidence-based critical control points where people have shown if we manipulate this point, risk can be changed? And we used scoping literature review methodology. We used the Web of Science. But at the end, only 30 papers were talking about this. But the evidence, and we'll talk a bit more about this a little later on in the presentation, was not very useful for finding confident causal evidence of spillovers. So I sort of said to myself, well, we've got to be missing something because everybody's talking about this. Everybody's talking at this time. People are making very confident recommendations about what to do. So I thought, are we missing something? Well, let's look at the three diseases that were most talked about in the literature: Ebola, avian influenza, and amphibian chytridiomycosis. So we did a second systematic review focusing only on those three diseases and asked, have there been systematically evaluated risk reduction programs? 35 papers met our search criteria. None of those programs were evaluated for effectiveness, utility, propriety, all those things we talked about earlier. I still was very nervous that we were missing something. So we said, let's do a semi-systematic review of the literature, taking 5 different databases with our keyword searches, take the first 250 hits in each of those databases and see, has anybody done implementation or evaluation studies on risk reduction in the wildlife trade? And we couldn't find anything. Finally, we said, I've got to be missing something. We reached out to 26 international experts and said, could you share with us gray literature, peer reviewed, on evaluated risk reduction programs? And nobody can think of anything. So sort of the tail end was the effectiveness, acceptability, feasibility, and sustainability of risk reduction interventions could not be established in the literature. So let me go through this a little bit more. Before I do, what did most of the papers we found cover? It was very much like that early review that I showed you for wildlife health and disease. The vast majority described pathogens or pathogen ecology. Some would describe the outbreaks and their associated harms, and those harms were mostly death and disease, sometimes economics. Some of the papers would try to track the spread of new diseases. There were a number of papers who were advocating for action, and there were a number of papers who gave opinions on what we should do. So going back to that first part of the critical control points, so we only had 1% of the papers that tried to systematically study determinants of emerging disease spillover within the wildlife trade. A lot described, a lot documented, but to try to understand the factors that were causing spillover as modifiable risk factors, we had 1%. Most of the trade is unexamined. So there was a very large bias to zoonotic pathogens because of our interest in what affects us. So less of an interest in emerging diseases that affected wildlife for wildlife's sake or even for agricultural sake. Bias towards species, primates, bats, and rodents largely. A heavy bias towards Africa as the source of studies, and large focus on animals used for food and some for live animal use, mostly pet trade. But all of those studies, when we reviewed their study designs, they were generally case series or cross-sectional studies. And those study methodologies are very weak to provide causal evidence. So we think about HACCP, which is a program that's used for, not a program, a process to think about how to reduce risks in manufacturing or food chains, right? You identify your hazards, you investigate their impact, you look for areas that are crucial for control, you look for places in the chain where it can control them and those points for impact. Most publications were describing the danger, investigating that danger, and opining on possible interventions. So we have this huge gap in the CP's parts of HACCP. So where should we act? There was generally 6 options were mentioned in the literature: closing or managing wildlife or wet markets, banning the trade, imposing sanitary regulations at markets and enhancing biosecurity, reducing demand by focusing on the consumer, culling populations that were the source of pathogens, wildlife farming, so you could contain the animals and have some control over their infection exposures, and socio-ecological interventions, which could be, managing and protecting habitat. It could be offering alternative occupations for wildlife harvesters, things like that. But of all those options, when people discussed them, there was a real divergence of opinion and evidence. We could find one paper that says closing markets works really well. Another one says it only works for a little while, and some say it doesn't work at all. Reducing demand, we tried it here, it didn't work. We tried it there, it didn't work. And really, when these opinions were provided, there was again this huge gap in evaluation studies. Most of those that did try an evaluation was very short term. And of course, this reflects our funding focus, where you get your 5-year project and you have to do your project evaluation the last 6 months of your program instead of coming back 5 years later. And the other question was, there was no consistency on what we described success of these programs. So was it changing the behaviors, prevalence of infection coming into the market, or just the presence of it? Because the challenge, of course, is how do you prove you've prevented an emergence? I like to take credit for every emergence that's never happened, but how could I prove that because it never happened? So we don't have a standard of saying what success would look like when we're trying to show this option works better than that option. So we sort of think about evidence-based decision making. As I said, that was our real focus. So there's four types of things you look at when making evidence-based decision making, particularly in healthcare settings. The scientific literature, which we've been talking about, practitioners, the experience and expertise and tacit knowledge of people who work on these areas, evidence within an organization, so data that they may have, experience they may have, and finally, the values and the concerns of the stakeholders. All those are taken into account when making evidence-based policy and health decision making, policy and health decisions. So the scientific evidence summary is this. So on the left-hand side, you see the three general categories of evidence that are used for evidence-based decision making. Again, pulling on a healthcare model. You want evidence that's specific to the decision-making context, both the social and ecological context. So I showed earlier that most of our literature is biased to discovering a threat and not on evaluating if a program works. Second type of evidence you look at is evidence extracted from other settings. Now, there are many, many, many papers, as you saw, on this issue of the wildlife trade and emerging diseases. There's also experience, say, with avian influenza and agricultural species, poultry, for example. But many of those were not specific to the context we're talking about, or as I mentioned, their case designs were not such that you could make confident cause-effect relationship conclusions. The third type of evidence you look at is evidence pertaining to the values and expectations of the decision makers and those affected by the decisions. And that, as we said, is grossly underexamined in this issue. So when we see that the types of evidence can be used for scientific evidence-based decision making, most is having to draw analogy from somewhere else. So um, sanitation in food markets for domestic food has been known to reduce foodborne disease. So maybe it should work here. Trade bans have reduced movements of pathogens across borders. Maybe it will work in this context as well. But what about the other three types of evidence? What about practitioner evidence? There's a lot of expert opinion out there, and most of that was from researchers who were from away. In other words, less being published on the expertise of local practitioners, people who are in that area, people who have that experiential and tacit knowledge of place. Um, Rarely were those practitioners' opinions assessed for feasibility, acceptability, or sustainability. In terms of stakeholders, there was a number of people in the literature who recognized that values that wildlife trade brings to their participants. For many people, as you all know, wildlife still is an essential form of animal protein and of income that are important for individual and community well-being. But again, most of these comments were externally generated rather than locally or internally generated. And finally, what about internal data, organizational data? Well, there was no real central repository for information and knowledge on this. So if somebody else wanted to do the same project, there wasn't necessarily a place that they could say, this is where I find what's going on. Or more importantly, there's no place where you could register your intervention. So in this particular market in Thailand, we did this. Here's how we evaluate it. Here's our experience. There's no place that I could put that where somebody else now who's in um, Mexico could go, I wonder how other people are doing this. So we really have a problem in diffusing local innovation globally. So many people are going to have to repeat the same thing because we don't have that centralized internal repository for information. So we kind of figure that the prevailing assumption seems to be that more knowledge about the disease will shape decisions. And we know from evidence-based decision making in public health, in clinical medicine, and in other forms of government that the acquisition of new knowledge doesn't necessarily shape behavior. I mean, this is very well known in human health behavior. Just giving people information doesn't change their behavior. So it really fails to look how we would manage those illnesses and how decisions are made, which are a combination of the best available evidence, scientific evidence, social evidence, experiential evidence, that combines with the resources and capacities that we have and the social needs and constraints within that context. If you don't have all those components, your decision making will not has a low chance of actually being implemented, impactful, or sustainable. Fundamentally, the question we're asking is why don't people act differently? Whether it's a consumer, whether it's a hunter, whether it's a processor, right? I mean, there's this sort of short risk tolerance model here. People have to be able to see that something's a hazard and recognize that it's a hazard to themselves, to what they value, as well as to others. They have to understand the risk and how it works, and they have to accept the change you're asking them to do is beneficial for them, is not going to be onerous. If they don't have those three things happening, they're going to continue these risky behaviors. But these questions were very, very rarely investigated, and the papers we found were found outside of our keyword literature reviews. So there's implications of these findings. Different experiences and opinions prevented the selection of a single best approach or combinations of approaches to use. So we could not say to the OIE in the end, if you do these three things, we'll reduce risk, and say it in a confidence, evidence-based way. Second, the nature, magnitude, and likelihood of unintended or unanticipated consequences were poorly quantified, so you could not do risk-benefit analysis of options. So, I mean, people have commented, for example, trade bans will increase illegal trade or will increase food insecurity or, these sorts of things. And because of that context specificity, because of the multiple species, because of the gaps of evidence on implementation, there's a high degree of uncertainty and unpredictability and context dependence that come through this interconnectedness, making our capacity to predict tenuous right now. So how about moving forward? So let's talk maybe about a knowledge to action agenda. So now I'm now going to depart from what the evidence told us to sort of our view of maybe what should go forward. So this is perhaps more editorial in this part of the talk. So the first thing I think we need to do is to develop a safety perspective of this rather than a risk. So we want to talk about changing these behaviors by increasing capabilities, motivating people to ask, and creating the opportunities. We know from psychological literature and from conservation psychology, people are more likely to sustain a behavior when it protects something they value rather than avoid a risk that might happen. And I mean, just sort of think about yourself and your daily decisions. It tends to be how we work. So it's still going to be important to enumerate and characterize risks and hotspots. But what we really want to do is identify, promote, and protect cold spots and safety. I want to know why this isn't happening here, how I can replicate those things, and how I can keep them safe rather than just piling more potential risk factors, which we know we're going to be context specific to. So even just start talking about safety rather than risks will change the discussion and may influence how people approach studying these issues. The second thing we have to reframe is we have to recognize that risk and safety is determined by the constraints and options we place on human decisions. So COVID is not a microbiological issue. It is not a conservation issue. It's a human issue. And I've just put two pictures here of models of decision making. The one at the top is what's known as the health belief model. The one at the bottom is the theory of planned behavior. These are some approaches and models that have been used to help people towards healthier or more helpful decisions. And just look at this for the second and look at how often the word beliefs and perceived shows up there. Attitudes, subjective norms, right? These sorts of things that humans aren't rational actors, and we know from the literature providing more data and knowledge does little to change behaviors. Things like, do I believe there's a threat to myself? And do I believe it's severe? Do I believe I'm susceptible? Do I believe there's going to be a benefit from it? What do my peers think? What's the social norm? Have they made it easier for me to do this? Do I have external cues? Do I have the resources? So there's a lot going on here if we want people to do something differently. And that really hasn't been studied at all. So these are the sort of the five stages to any sort of behavior change. We start that somebody's unaware of the problem, so we make them aware of it. And then we make them aware that there's something you could do to reduce that harm. And then people say, okay, I'm going to intend to do something. And then you help them to do something. And then we help them to keep doing it. And then they maintain it. We want to get up that point where we maintain safe behaviors in the wildlife trade, but our research gets stuck at the bottom of making people aware. So we need to close that gap in behavior change if we really want to see risk being reduced and safety being increased. So we have to start thinking about, this hierarchy of decisions we make to decide what we are going to do. So we start with what's suggested we do. So how can we take the science that's generated, what we know might change, and match it to the needs of the group we're trying to change? So the suggestion is tailored to the context. Then you have to say, well, what can we do? What's technically, physically, legally, ethically possible? So it's not just running like a clinical trial, it's also understanding these other social aspects of it. Then you have to ask, what do we want to do? Even though it should be done and it can be done, people may not want to do it if causes inequitable outcomes, if the burden isn't shared, if it seemed to be unfair, if it conflicts with social values. And then finally, we ask the question, what will we do? And this is where we need to start studying implementation opportunities and constraints. So there's a hierarchy of researchable questions here that we need to start working on in order to help people make safer decisions, because that's what it's about, helping people to make the decisions. So this requires us thinking about a program of activities to create enabling environments for safety. And I think that's key. We want to create the environments that people can make these choices. Now, in some cases, we might force them to do it, right? They must do it. But even if they must do it, it has to be preceded with an understanding of why we need to do it. So we have to increase people's health and environmental literacy so they understand this relationship between our health, their health, and the world around us. They know why. Again, if we legislate it, they still have to be able to do it. So can we make sure that legislation is adaptable to local context and resources? I do a lot of work with small island nations, and here's just one more thing we're going to ask overstretched government resources to do. So that poor person who has to worry about invasive species and introduced diseases, and now the wildlife trade. No, by the way, do climate change as well. And it's one person and their budget hasn't gotten any bigger. And even if we ask the individual who might be the wildlife trapper or hunter, we want you to do something different. Can you give them those options to do it? And then more importantly, can we then develop the capacities and the systems so they want to keep doing it and they can keep doing that? And we can't do that without understanding how to create that environment that empowers people to make safe choices. So this means we need an empowerment agenda. And by empowerment, I mean helping people get greater control over the decisions that affect risks in the wildlife trade. So how do we affect their motivation through influencing social norms, or maybe it's legislation? How do we make sure they have the knowledge and competencies to manage those risks? How do we make sure they're aware of and can choose to be involved in these co-management of their health and animal health? How do we help them to adjust their behaviors by creating skills and resources? And how do we maintain those through giving long-term investment? So this really means we need some new models of leadership on these issues. That is not a top-down, but it's a local and a collective leadership. It's not the expert from Washington flying to somewhere and telling them what to do. This has to be a collective decision. So it's not an individual anymore, and it's not external. We need to start doing this more in a way that life is lived, which is within the context of everyday life. We have to move from this hierarchy from data and information to knowledge and wisdom. So data is about what we're seeing. And as I said, there's lots of data out there in the wildlife trade. There's lots of information where people analyze it and put on odds ratios and relative risks and p-values. There's some talk now about why it matters, but it's often biased to why it's mattered and often biased to the global north as to why it matters in the conversations. But how do we put this into context and connect it with other forms of information to people so it creates meaning? And more importantly, whose job it is to create the wisdom that answers the question, should we act? By weighing multiple types of knowledge, including social values and goals to help make a decision. Whose job is that? We also have to systematically start to find where are the gaps in implementing our knowledge, taking it from knowledge generation to action. And there's several gaps that I've highlighted here in red. So there's some gaps that are just on what is the risk and what could affect it and how is it changing. So surveillance and research, and that's everybody wants to invest in surveillance. They want to, what's surveillance? But we got to make sure why are we doing surveillance? Okay, now we have some surveillance information. How do we turn that into useful knowledge? So we have to develop context by paying attention to the situation, trends in the population, trends in the society, through things like health intelligence. Well, now we have this information that we should do something. How do we decide what we should do? So we need an action-oriented research agenda that actually studies how to do stuff under real-world context. And that leads us to implementation research, where we have to understand how do we keep things doing, what works for whom, where, how, and why. And then an important arm of evaluation, so we can sustain the doing and understand how to constantly improve. This means developing strategic and explicit knowledge mobilization plans. So this is one we developed for the report, where we could say, okay, say you're in a situation and you want to fix something here now. Your first question is, do I have the knowledge here to act? Is there a gap? If there's no gap, if you know everything you need to do, but it's not happening, well, now we start looking at regulatory and governance interventions, enforcement, standards, social incentives, things like that. Well, if there's a gap, can I get the information I need? If I can't do that, okay, I need to do knowledge generation like surveillance or research or consensus conference or risk analyses. Okay, if there's the knowledge out there, can it be shared with me so I can apply it locally? If that's not the case, there has to be investment in knowledge brokering, getting information from people who have knowledge to people who need knowledge. That might be evidence-based decision-making capacity building. That might be figuring out how to incorporate and share local interventions and knowledge. And it might be, how do we centralize the knowledge? Well, if the knowledge can be shared, can I apply it? Can I apply it here to make a change? Do I know how to do that? Well, if the answer for that is no, we have to start doing implementation science and support. That might mean lobbying for funds to do that, changing how funding agencies look at programs, and how do we actually do implementation monitoring and evaluation. Finally, if I can apply it, can I learn from it so we can improve our risk prevention? If the answer for that is no, we really need to invest in program evaluations. The other thing we need to do is start studying the problem as it truly exists. I mean, the One Health paradigm is to take an interdisciplinary approach to a problem. So we take a problem, a viral emergence in bats, and we have people from public health and sociology and veterinary sciences and economics to study this issue. The problem is the world is not interdisciplinary to single problems. The world is interproblementary. This is my other made up word. In other words, no thing is affected by one thing at a time. Within the wildlife trade, there are issues of income inequity, food insecurity, climate change, urbanization, habitat loss. We have to start thinking about how we look at these problems as interconnected wholes, rather than carving one piece off and having an interdisciplinary group at one piece without being connected to these others. Primarily because the origins of many of these problems and the solutions to them are interconnected at their distal upstream causal factors. So just to synthesize this, I'm almost to the end here. I took a look at literature on complex systems management. And on the left are the principles. And you'll see how the principles of complex systems risk management align a lot with what we found in this review. So the first step is, if you're going to manage this, you need to set your scope of practice with the boundaries and your objectives and your priorities, because you can't do it all as a program. There are no natural, all-inclusive boundaries between wildlife health and emerging risk. There's so many things interconnected to it. So if you have boundaries on your program, it helps you focus the skills and knowledge that you have. It helps you identify the successes you're trying to build, and it helps you identify the necessary partnerships that you need to develop to work on the whole problem. Second principle is, this goes back to my idea of safety, promote prevention as a guiding principle. So rather than only getting good at finding it, containing it, and acting quickly, we need to develop a shared value of prevention that encourages actions in advance of harm. I'm getting old enough now and cynical enough that I'm highly skeptical that the enthusiasm for COVID will last a long time. We have in the past have going to die of things that were horrible and really bad, nuclear war, pollution, and then we habituate to it and we move on. All of those things are sharing these shared drivers that cause harm, and we need to figure out how to prevent them and build resilience, as well as chasing the harm itself. We need to have some standards and processes for how we're going to act. So, how do we take existing programs as well as develop new ones so we can look holistically and develop standards so we can assess and apply the evidence? So, you noted earlier on, I said where people are talking about options, we don't have a standard view of what success looks like or how we would recognize it. You must monitor your system, not only monitoring the drivers of risks that we talked about in vulnerability, which changing with exposures or sensitivities to avoid being surprised, but also tracking how your program's working. Are we in fact tackling the appropriate outcomes? Are we seeing the right risk factors being monitored? Are we seeing these upstream drivers of threats being dealt with? The next one is create capacity for situational self-awareness. So this is, again, it's adaptive management. This is a changing, rapidly developing field, and we have to know how we can quickly and effectively adopt new information and adapt it as it arises. Fifthly, you want to optimize local efficiency in these complex systems. You need to consider what's happening locally. So other threats and other opportunities are taken into account when you're planning your interventions. Because you really can't manage emerging disease risks in isolation from other unexpected or expected impacts, especially in this era of climate change. You have to facilitate novelty and diversity. Science funding agencies are very conservative. Apart from, let's say, molecular technology, the fundamental approach to these diseases are not a lot different than in the 1950s. So we need to figure out how we can assess, clarify, reinforce, and amplify locally and internationally developed innovations. And how do we facilitate the diffusion and adoption? We have to take some risks on novel ways of thinking about these new teams, new perspectives, and figure out how to bring those together and not do a status quo approach to research. That means we need to facilitate connections, interactions, and collaborations because those build trust. Um, uh, this is hard to do when you can't meet people, but community action, risk reduction action needs to have information come from trusted sources. So we need to know each other, respect each other's competencies, and be willing to share information, which is very difficult, particularly across some disciplines and countries. And most importantly, we need to learn from each other to foster collaborative interventions. And then finally, we need to address this as an issue of human choice and decisions. And we need to pay particular attention to those aspects of society that impede or enable people to effectively manage risk. So knowing what works is not enough. You need to know what works for whom, when, and where. We are in the business of changing human behavior. Giving data and information is insufficient. Helping make safer decision easier is what we need to do. And there's a robust literature on that in the public health field and in marketing fields and other places. So we really need to have a strong human dimensions aspect to this. The gap between knowing to doing is unacceptable on this and many other animal health issues. So we must enhance our program evaluation and implementation science arm. We can't just be relying on people with many years experience in telling us what they think will work without asking, without holding them to account to say, prove to me, what is your evidence base for this? How will you monitor this? How will you show it's effective? What's effective? So it's very clear that something new needs to be done. Repeating the same science, the same policies that we've used that got us here is not going to be enough in this times of unprecedented social and environmental change. But it's much less clear on how to unfreeze us from this status quo. So we really need groups such as the group we're talking with today to have an advocacy for an action agenda to balance the discovery agenda that predominates this issue right now. So with that, I just want to say thank you. I will stop sharing my screen. These are just a couple of books we have that sort of talk about some of these issues in practice. And I'm happy to take any questions or hear a discussion afterwards. So thank you for that.
Thank you so very much. I'll do this.